Hi, welcome to the lung page. Today we are going to discuss a clinical guide to post-operative respiratory complication. How can we manage post-operative respiratory complication? We'll see one by one. So, anatomical mapping of major respiratory related post-operative complications, mainly for we'll see one by one. Atelectasis, so collapse of alveoli, exacerbation of previous illness like COPD or asthma, sometimes pulmonary edema, pneumonia, hospital-acquired pneumonia or ventilator-associated pneumonia, respiratory failure, and pulmonary embolism. These are the common post-operative complications can occur during the ward stay or ICU stay. So we'll see. So we'll see the diagnostic matrix and common infection. So we'll see the most common cause is atelectasis. The pathology is collapse of alveoli due to decreased functional residual capacity during anesthesia. So in this time, what will happen? Bacteria infection to the lung parenchyma can develop. Sometimes the typical timing for the onset of this atelectasis develop after post-operatively nearly first 48 hours within first 48 hours of the post-op. So this is the timing period of atelectasis. So these are the triggers that lead to pneumonia, hospital-acquired pneumonia, VAP or ventilator associated pneumonia. So typical timing of developing of the pneumonia is post-operatively nearly 3 to 7 days. So main reason for this atelectasis and aspiration. So this is the basic. So we'll see one by one. So what are the systemic complications? So previously we saw the infective problems. Now here we can see the systemic and vascular problems, mainly respiratory failure, okay, and hypoxemia or hypercapnia can develop. And then exacerbation of the chronic disease like asthma or COPD. Pulmonary edema can occur and also pulmonary embolism can also trigger, right? So this is the infection or these are the complications can develop after post-operative. Okay, so what are the risk factor triad to compounding the post-operative patients? Mainly low albumin level. Albumin level is low within the no without the normal level is low. It's definitely there's a problem. Then patient-related condition like patient age is more than 60 years, smoking history, and ASA class is more than 2, and pre-existing lung disease like COPD, asthma, and obesity and sleep apnea. So these are the patient-related risk factors for developing post-operative respiratory complications. And also procedure, intraoperative surgical procedures, mainly thoracic surgery, abdominal surgery. So mainly thoracic surgery is very high risk of the post-operative complications. And also emergency surgical status and surgery duration is more than 3 hours. So that also the problem for developing post-operative respiratory complications. So anesthesia related problems, when you see the anesthesia risk, it's a very high risk compared to the regional anesthesia because this general anesthesia very high risk of developing atelectasis and also this patient develop infection as well, and also prolonged acting neuromuscular blockage. So this also can develop problem to the patient because of this atelectasis. So how can you predict the risk of the post-operative respiratory complications? So predictive scores are like ARISCT, ARISCT score, and Gupta PCR calculator. So most widely validated use is ARISCT score. So its variables are usually 7 predictors, mainly age, post-operative, preoperative saturation, and respiratory infection in the past month, and preoperative anemia, and surgical incision site, duration of the surgery, and emergency status. So when we go through and put this calculator, this is widely available in the internet. So you can use this ARISCOT score. So it will predict the risk of post-operative complications. Okay, I think now you're clear about these post-operative complications. How can we assess this patient pre-operatively with these scores? So what are the pre-operative preventive continuum? So when the patient develop this post-operative respiratory complication, how can we prevent? So prevent mainly the 3 categories: pre-operative, pre-operative optimization, and intraoperative protection, and post-operative care. So in the pre-operative optimization mainly focus on the patient physiological and baseline modification behavior. Intraoperative minimize the mechanical trauma and pharmacological respiratory depression. So these are the main thing. And postoperative mainly focus on active lung expansion and immediate mobilization. These are the main key factors for prevent the postoperative respiratory complication. We'll see one by one. So when we see the pre-operative optimization from the baseline, smoking cessation is very important. So must patient withdraw the smoking 4 to 8 weeks prior to the elective surgery. That will effectively reduce the complication of post-operative complication. And inspiratory muscle strengthening exercises, target breathing exercises designed to strengthen respiratory muscles that reduce the post-respiratory complication rates in some risk groups. And also medical optimization is very important. Ensure the maintenance of pharmacological therapy for the pre-existing condition like asthma and COPD. They strictly maximize the treatment. So then only we can prevent the post-operative complications. So these are the pre-optimization of the pre-operative optimization. So what are we are going to do in the intraoperatively? Intraoperatively, main thing is lung protection ventilation is very important. Strictly adhere to the low tidal volume, 6 to 8 milliliter per kilogram, that body weight. So with a moderate weight, that will prevent the intraoperative lung injury. Also, judicial fluid management is very important, that prevent the pulmonary edema. And also some anesthesia, respiratory depression anesthesia, it will lead to prolonged respiratory depression, and also neuromuscular blockage also will we have to minimize those things. So that will prevent the post-operative complications. So what we are going to do in the post-operatively. So early mobilization is very important. When the patient is early mobilization, ask the patient to encourage to sit up and walk as soon as possible. That will prevent the almost all the complications like that venous embolism, and also prevent the lung eclectasis. So effective analgesia is very important. So if the patient is in pain, the patient can't breathe properly. So that will lead to shrunk the lung or develop the eclectasis. So effective analgesia is very important. Lung expansion maneuvers like incentive spirometry is very important. So that will prevent the lung eclectasis. And head elevation is very important for the abdominal surgeries. So these are the things we will measure the important care for the post-operative care that will prevent the post-operative complications. So in the summary, we'll know early identification is very important. Who are the people who are very high risk? We can use this ARIS score and Gupta score for each and every patient for the post-operative operative patient to identify which patient is very high risk for the post-operative complication. And also optimization is very important. I told previously, pre-operative and intraoperative and post-operative optimization is very important. And pre-operative is very important because of this. The patients stop smoking, that will increase the, that will almost prevent the post-operative complications. And also lung protective mechanism and recovery post-operative triad, mainly the analgesia and incentive spirometry and immediate mobilization. So this is the summary diagram. How can we prevent the post-operative respiratory complications? So when we all know COPD and general anesthesia, so this is the myth. Sometimes they told COPD patient contraindicated to general anesthesia, but that's not the absolute contraindication to general anesthesia. But in severe or unstable COPD patient can be the relative contraindication due to the high perioperative risk. So when the GA is high risk or relative contraindication COPD, so it's very important acute exacerbation of COPD, that is relative contraindication. Severe airflow limitation, FEV1 is less than 50 is with frequent exacerbators are the relative contraindication of very high risk patient of general anesthesia. And chronic respiratory failure, type 2 respiratory failure, PCOT is more than 45. These patients are very high risk for post-op complication. And hypoxemia, PO2 less than 60, very high risk. And pulmonary hypertension, that patients are very poorly tolerated to general anesthesia. And sometimes bullous lung disease, that will develop some barotrauma or pneumothorax post-operatively. So these patients have related contraindication for COPD. And also poor lung function capacity, poor exercise tolerance. These category of the patients are very high risk of GA patients and the COPD category. So I summarized here with a nice chart. You can save this one and share with your friends and learn how we can prevent the post-operative lung complications during the surgery and after surgery. Okay, thank you very much, and subscribe my channel and follow in the Facebook as well as the TikTok. Bye, we'll see you later.